Thank you for the invitation. It's been a pleasure to be at your meeting and to visit Taipei for a few days. It's really been a true pleasure. First, I would like to acknowledge two of my colleagues, Dr. Messicard and Dr. Dominguez, who I work closely with in Colorado, and they've helped pull together a lot of the information that I will be presenting today about the emergence of Enterovirus D68. For those of you who don't know where Colorado is, here is the United States, here is Canada to the north, Mexico to the south. Right here is Denver, Colorado. We're not in an area that gets hurricanes or typhoons, fortunately. It's a beautiful city, and even more beautiful are our mountains, and this is my hospital. So today I'd like to talk to you about Enterovirus D68's emergence as an epidemic respiratory pathogen, present data at least associating this virus with acute flaccid myelitis. I'll briefly mention the molecular epidemiology as we understand it thus far of Enterovirus D68, and at the end discuss prospects for therapy and potentially vaccination. So I'll start my story with the summer of 2014 at our hospital in mid to late August, where we noticed an increase in respiratory disease. And that's represented here by an increase in respiratory hospital admissions in this summer season compared to previous years, and also in the outpatient metropolitan area, a spike in respiratory illness. With recognition of this, we sent specimens that were rhinovirus, enterovirus positive from the nasopharynx to CDC in Atlanta, and they identified Enterovirus D68 in the majority of these specimens. Similar reports were occurring at the same time from some other nearby children's hospitals in Kansas City, Missouri, in Chicago, Illinois, and gradually there was observed spread of Enterovirus D68 from August to October throughout much of the United States. And this was an interesting time in the US because this was at the same time that Ebola virus was emerging both in Western Africa as well as spreading in Europe and into the United States. So these two viruses had Americans on edge. So what is this virus and where did it come from? It's a unique enterovirus, biologically in many ways more similar to rhinoviruses than to the enteroviruses. It optimally grows at 33 degrees Celsius, so at a cooler temperature level than usual body temperature where most enteroviruses prefer. It's heat and acid labile, so it tends not to survive through the gastrointestinal tract, but prefers to replicate in the respiratory tract, and in fact is transmitted via respiratory secretions more so than by stool. And in fact, this virus was originally classified as a rhinovirus number 87. As you might expect then, most diagnostic specimens have yield from the respiratory tract, particularly the nasopharynx. Occasionally found in the serum, it's uncommonly found in the stool, and thus far very uncommonly found in spinal fluid. Multiplex or multivirus respiratory PCRs are not generally able to distinguish rhinoviruses from enteroviruses. So if we have a specimen that's positive for rhinovirus or enterovirus, we usually need more specific sequencing to confirm the presence of Enterovirus D68. And now, with this outbreak, there have been a number of real-time PCRs that are specific for Enterovirus D68 that have been designed and that have enhanced sensitivity. So where did this virus come from? It was first identified in 1962 from a few children with respiratory illness, but it remained uncommon until 2008, and Dr. Watson yesterday mentioned the National Enterovirus Surveillance System in the United States, where it was a very uncommon pathogen for these 35 years. But then from 2008 to 2010, a number of small clusters of Enterovirus D68 infections were reported, usually very modest size clusters, several states of the US, a number of countries in Asia, and several in Europe. This expanded then from 2010 to 2014, with increasing number of countries throughout the world reporting clusters, again, generally modest in size, with the largest being a cluster of 120 cases reported in Japan. And where active surveillance was done overall, this virus was a rare cause of disease. But a number of prescient investigators made some telling comments from Japan. Findings from these studies and our studies suggest that Enterovirus 68 infection may induce a small-scale epidemic. And from England, this study corroborates previous evidence that a rapid change is occurring in Enterovirus 68. Enterovirus 68 is an emerging pathogen that requires global monitoring. And they were right. So this virus spread throughout the entire United States in 2014, causing a large outbreak with 1,153 confirmed patients infected. In most of the United States affected, the majority of cases were children from 1 to 11 years of age. There were some cases, but lesser amounts in adults. And primarily, this was a respiratory epidemic. During this period, the CDC received 2,600 specimens, about a third of which were shown by typing to be due to Enterovirus D68. This virus was recovered from 14 children who died. And in this Time magazine article, this was the first of the children who died. Eli, one of three, a set of triplets. And the CDC commented that likely there were millions of milder Enterovirus D68 infections for whom care was not sought and therefore testing was not done. So this was the likely tip of the iceberg. The epidemic wasn't just a US phenomenon. It was observed worldwide with a number of countries and continents showing evidence of Enterovirus D68 spread. But there was a consistent picture of unusually severe respiratory illness. Although outpatients were certainly involved, there was an overrepresentation of detecting this virus among sick, hospitalized children. And the hallmark clinical finding was wheezing in over 2/3 of patients, either representing an asthma exacerbation, children with pre-existing asthma who now had a hospitalization with this virus due to a new episode of wheezing, or new onset wheezing in children who had no prior history of wheezing illness. There was a spectrum of mild URI, upper respiratory infection, to intensive care, which was required generally in more than half of inpatients, as well as smattering of reports of immunocompromised adults who were affected by this pathogen. This is one series that I like from our CDC, which summarized the clinical findings of hospitalized patients. The median age was 5 years. You can see again that peak from 1 to 11 years of age. More than half of patients having pre-existing asthma or reactive airway disease. The symptoms and signs were that of respiratory distress, so dyspnea, cough, hypoxia, wheezing, whether or not the child had a previous history of wheezing illness. Only about half of patients were febrile, so that was an unusual phenomenon for an enterovirus illness, which is usually characterized by fever. And about 60% had abnormal chest x-rays, with the findings suggestive of reactive hyperresponsive airway disease. Most patients required supplemental oxygen. Many of the patients, as I mentioned, needed ICU care. A significant percentage required some sort of ventilatory support, all of which was more common in patients who had pre-existing asthma. Most patients required bronchodilator therapy, but fortunately, although the illness was acutely severe, most patients responded well to therapy, and death was actually a very uncommon phenomenon. As mentioned, there's a very tight association of this virus with asthma. So children who have pre-existing asthma had an increased incidence of medically attended Enterovirus D68 and high hospitalization rates. And compared to other viruses that we know can be problematic in children with asthma, like rhinoviruses, and to a lesser extent, respiratory syncytial virus infection and influenza, Enterovirus D68 seemed to be a worse player, with higher incidence of wheezing and respiratory distress compared to even these other viruses long known to be problematic in children with asthma. And this is a report that just came out a couple of months ago looking at nasopharyngeal aspirates from children who were infected with Enterovirus D68 and compared those with Enterovirus D68 to specimens from children with rhinovirus. And they identified an excess amount of interleukin-17 messenger RNA in the nasopharynx. IL-17 is one of probably several interleukins that are increased in the airway of children who are infected, and IL-17 is associated with a pro-inflammatory state, increased interleukin expression, as well as increased neutrophil response, and this may help explain the hyper airway responsiveness seen with this infection. So globally, I mentioned the epidemic certainly spread beyond the United States in 2014, and then if we look over time, there were relatively few detections in 2015 in the United States and Europe, but more so in Asia, including Taiwan, but especially China, Hong Kong, and Japan. 2016, there was again renewed detection in the United States, but on a more sporadic basis with relatively few well-defined outbreaks, the largest being 160 cases in the lower part of New York State. There was also Enterovirus D68 respiratory disease described in many other countries in 2016. And then, like 2015, in 2017 globally, there seemed to be, again, a drop in the number of reported cases. This is data that Kevin and at our institution put together at looking at our surveillance. Again, in 2014, we saw this peak of Enterovirus D68 detection. No cases in 2015, a lower amount of cases in 2016, and none in 2017. So that is part of the story. The other part of the story is at the same time that we observed this respiratory outbreak, we noticed an increased number of cases of acute flaccid myelitis, some of which also had evidence of cranial nerve abnormalities. And this is the epidemiologic curve showing in the purple bars the cases of acute flaccid myelitis during the same period as the respiratory outbreak of Enterovirus D68 in the summer of 2014. From the 12 cases of neurologic disease, we had specimens from 11. 5 of them, or 45%, had Enterovirus D68 detected in the nasopharynx. None of them were spinal fluid positive for an enterovirus. And then when we compared the cases of acute flaccid myelitis seen during this period, compared to the cases we'd seen in the previous 3 years at our institution, you can see a statistically significant rise in acute flaccid myelitis associated with this outbreak period. This report prompted the CDC to gather cases reported nationally of acute flaccid myelitis during the 2014 epidemic, and 120 cases were ultimately reported from 34 of the 50 states. Among respiratory specimens, Enterovirus D68 overall was identified in 20% of cases, but up to 47% in cases where a respiratory specimen was obtained within the first 7 days of illness. The virus that was detected was the B1 subclade, which was the same as the respiratory outbreak strain. This strain had a number of sequence similarities to other neurotropic enteroviruses, poliovirus, Enterovirus D70, and A71, other viruses that can cause paralytic disease. But these sequences were present both in respiratory disease cases as well as neurologic cases. There was also a smattering of other enteroviruses and non-enterovirus detected in other cases beyond those from whom Enterovirus D68 was detected. And again, spinal fluid was usually negative both by direct enterovirus PCR as well as next generation sequencing. This slide summarizes the clinical profile of the children with acute flaccid myelitis. They were generally previously healthy children, school-aged children who had a prodromal, usually respiratory illness, often with fever, but not always. And that preceded the neurologic phase by a median of 5 days. Then onset of neurologic disease with fever, headache, neck stiffness, pain often involving the extremities, as well as the neck and back. And then within 1 to 2 days, rapid progression to extremity weakness. This flaccid weakness could involve any of up to 1 to 4 extremities. More typically upper extremities than lower extremities, more frequently proximal more than distal, and most often asymmetric, very much like poliovirus or enterovirus A71. Hyporeflexia was the rule. A variable rate of cranial nerve dysfunction, but usually involving bulbar palsies. So hypophonia, dysarthria, dysphagia due to cranial nerves 9 and 10. Diplopia, facial weakness. A minority of cases had bowel or bladder dysfunction, more so in adult cases than in children. Sensation was usually intact. In most cases, cerebral function was quite normal. Normal mental status, lack of seizures. And these patients, as I mentioned, had a rapid progression. They reached their nadir quickly within a few days. This slide looks at the imaging that was found by magnetic resonance imaging. Typically, early on, the central gray matter was involved. This progressed to anterior horn disease over time, usually non-enhancing increased T2 signal, sometimes with spinal cord edema present as well. As a rule, the illness, the imaging findings were longitudinally extensive, as shown here, with a median of 10 to 17 vertebral levels that were affected. Again, mostly in the cranial spinal cord. Over time, also, many cases showed ventral nerve root enhancement, but that sometimes took weeks to months after the initial presentation to show up. A third to 3/4 of patients had brainstem lesions, most often affecting the pons, medulla, midbrain, and the dentate nucleus. Cortical lesions were uncommon. Electromyography showed a pure motor anterior horn cell disease. And again, here you see the anterior horns of the spinal cord affected by imaging. And most cases had a lymphocytic pleocytosis. Recovery was variable. In most cases, persistent deficits were observed. Sometimes pain and atrophy continued as well. But there were functional improvements observed with rehabilitation therapies. So here is a report of outcomes after a year of follow-up. In most cases, cranial nerve dysfunction improved or resolved, but limb weakness, although it may improve, most cases were left with some long-term deficit and often with atrophy, as shown in these pictures. The MRI generally improved over time, but the EMG showed ongoing denervation. And in those cases that had documented Enterovirus D68 infection, they seemed to have a worse overall prognosis. So looking at the epidemiology, here is 2014. Here is the large outbreak represented with 1,395 Enterovirus D68 detections by the National Enterovirus Surveillance System. This was our #1 Enterovirus isolate in 2014, and this was the associated spike in acute flaccid myelitis cases. In the US in 2015, very little Enterovirus D68 disease in 2015, and a modest number of AFM cases. 2016, we certainly had Enterovirus D68 detected, less so clearly than 2014, but it was still our #1 circulating Enterovirus that season, and another spike in AFM cases. 2017, not so much Enterovirus D68 circulation, very little AFM again, and so far, at least through August in the United States, not much AFM in 2018 report. So a close temporal relationship between AFM spikes and Enterovirus D68 circulation. Similar findings were observed globally. A number of reports from many countries now found associations of Enterovirus D68 detection and cases of acute flaccid myelitis. The next talk will discuss specifically about Japan, so I won't go into detail about this, but I do want to just make 2 points from this report. One is a case with spinal fluid detection of the virus, and also a interesting finding of anti-ganglioside antibody detection in about 1/3 of patients from the serum of cases of acute flaccid myelitis, suggesting that maybe there's an autoimmune component that might be triggered by the viral infection. Other series, for example, this one from Argentina, also occasionally have been reported with CSF positivity. And this table summarizes the various countries where Enterovirus D68 associated AFM have now been reported, and you can see the numbers associated with each of these reports. And over time, increasing, albeit small numbers, of cases where the virus has been found in the spinal fluid. So this temporal and geographic relationship, the consistency of the clinical syndrome, detection of Enterovirus D68 in cases with AFM had a pretty consistent rate, a small number but increasing number of CSF positive cases, all make the association very suggestive that this virus may be the cause of acute flaccid myelitis. We certainly have precedent from other enteroviruses, including polio and Enterovirus A71, that cause CNS disease and myelitis in particular. And we have potential transmission routes. Viremia has been documented. We also know that Enterovirus D68 can bind to intracellular adhesion molecule 5, which is present on cranial nerves 1 and 2 and in the cerebral cortex. So that suggests a possible way for a virus to move directly either through the bloodstream or directly from the nasopharynx into the central nervous system. And then we also now have a couple of mouse models where the 2014 strains of Enterovirus D68 have been shown to cause myelitis and in some cases myositis with anterior horn cell infection, paralysis, and death. So a mounting body of evidence suggesting that there is a true association and potentially a causal relationship between this virus and acute flaccid myelitis. I want to mention, if you go back in the literature, a Dr. Hopkin from Australia reported in 1974 10 children with acute paralytic illness resembling polio that occurred 4 to 7 days after an acute wheezing illness. And imaging from this report, as well as some other similar reports that have followed, look very similar to that which we see with Enterovirus D68 disease. And makes one wonder whether we now know the cause of what was then called Hopkins syndrome. And maybe this represents Enterovirus D68 that was circulating then, but we didn't have the tools to detect it at that time. So I think that's very, very interesting. Now, a word about the molecular epidemiology. We have so far had descriptions of 4 different clades of Enterovirus D68 and several subclades within these clades, so clades A, B, C, and D. Studies thus far have showed significant genetic diversification occurring globally since 2000. And around 2010, clade B1 emerged, and this was the dominant clade in the 2014 respiratory and AFM outbreak both in the US and Europe. And evidence shows that this has recently evolved with a number of distinguishing mutations and substitutions compared to previous B1 strains, a number of which are residues that are very similar to those seen in polio, Enterovirus D70, and Enterovirus A71, again suggesting a possible reason why this association with AFM may be something that we're observing increasingly in recent years. The other important strain that has emerged is clade B3 that emerged in 2013 to 14, and that's a strain that has been dominant in Asia, particularly at the beginning in 2014 and especially in 2015, and now has also spread worldwide, so that this was also now the clade that was dominant in the US cases as well as in the European cases that presented in 2016. AFM, both in humans and animals, has been observed with both A and B clade strains. And much like Enterovirus A71, recombination has been demonstrated with Enterovirus D68, mostly intra and interclade, not yet, to my knowledge, between Enterovirus D68 and other enteroviruses. And again, like Enterovirus A71, there is evidence of genogroup co-circulation and genogroup replacement. So this is from mainland China, showing here that genogroup A was their dominant serogroup until more recently, where there was co-circulation with B and then ultimately replacement with B. And speculation is that some of these replacements, like for Enterovirus A71, may be reasons to see spikes in disease prevalence. And I just want to mention a few things about therapy and vaccination to conclude. We don't have any specific antiviral therapies yet for Enterovirus A71. I think this molecule, DAS-181, is an interesting candidate. It is a nebulized medication that is being tested for influenza and parainfluenza virus infection. And it works by eliminating sialic acid receptors in the airway. So it's a recombinant fusion protein that includes a sialidase and a glycosamine binding tag. This tag anchors the drug to respiratory epithelium. The sialidase then cleaves sialic acid cell receptors. And it turns out that these receptors are not only receptors for influenza and parainfluenza virus, but also for Enterovirus D68. So this drug has been tested in vitro against Enterovirus D68. It's very potent. It has not yet been studied in vivo for Enterovirus D68. It has for influenza, where it shows good efficacy. For AFM, we're left with supportive care as the only approach. That includes respiratory and autonomic support. We tend to use intravenous immunoglobulin, which does contain neutralizing antibodies to the key D68 strains. In a murine model, it has been shown that IVIG does decrease viral loads and reduce paralytic disease and death. In humans so far, we don't have good evidence that it's beneficial or harmful, but we're trying to collect that information. Sometimes in humans, plasma exchange has been used. There's a hypothetical risk of potentially removing protective antibodies. So that tends to be a later therapy in patients who are really not doing very well. So far, again, we don't have good evidence of either improvement or harm with this therapy. And likewise for corticosteroids, in the mouse model, there is some concern with steroids where it did show increased viral loads and increased motor impairment and mortality. In humans, where steroids have been used, so far, no clear evidence of improvement or harm, although we do use it for acute cord swelling when that seems to be present. Fluoxetine, a serotonin reuptake inhibitor, an antidepressant, has been shown in vitro to have good activity against many Enterovirus B and D strains. So it has been evaluated as a potential antiviral for Enterovirus D68. It was shown in vitro to have good activity against EV-D68. In the mouse model, no effect. And Dr. Messakar at our institution has been collecting retrospective data from children in the US who were treated with fluoxetine in 2015 and 2016. And so far, the data that we've looked at has not shown evidence of benefit or harm. But this is a retrospective analysis. Cases were not randomized, so in most cases it was the more severe disease that was treated, so there clearly is an indication bias present. So we can't say for sure that there's no benefit, but so far we haven't seen evidence of it. Physical therapy and occupational therapy are provided early to improve function, and there's now just the beginning of some experience using nerve transfer surgery to try to improve some of the long-term motor deficits. This is Dr. Messakar's summary of the fluoxetine data that he's collected. He'll be presenting this in San Francisco this coming week. Here are the cases that were untreated with fluoxetine. Here are the cases with fluoxetine treatment. These are the motor scores, higher being better. And you can see that those children who did not receive fluoxetine actually did better than those who received fluoxetine. But again, remembering that fluoxetine was disproportionately used in cases where EV-D68 was identified, and in cases that were more severe at baseline. So I wouldn't conclude from this that fluoxetine made for a worse outcome, but I would say that with the limitations of the retrospective data in a non-randomized setting, we don't see a strong evidence suggesting signal. And then finally, to conclude on vaccination, there have now been a couple of reports from Japan in particular, as I recall, where newborn mouse models were studied and a number of different vaccine candidates, one an inactivated vaccine, and on the next slide, a virus-like particle vaccine, were studied and given to adult mice. Antisera was then collected, given to neonates prior to viral inoculation. That protected newborns, and in a parallel experiment, vaccine given to mother mice or pregnant mice who then deliver their babies. The babies whose mothers received vaccination were protected against paralytic disease and death. And I won't go into the details of the slides, but there are pretty dramatic effects, again, seen with both model candidates. So we have the hope for vaccination should Enterovirus D68 be proven to be the cause of neurologic disease, and should it continue to be a problem. Well, I want to conclude just by giving you a picture of where we are in 2018 in the United States. We have had a reappearance of Enterovirus D68 this summer at our hospital, as well as a few others in the United States and a few countries thus far in Europe. This shows at our hospital a spike in respiratory rhinovirus or enterovirus detection beginning in August and continuing into September, of which overall 16% of these have been shown by CDC to be due to Enterovirus D68. So we're seeing an upswing in respiratory disease, not nearly to the magnitude of that seen in 2014, but some nevertheless. Thus far, we've seen 1 or 2 cases in Colorado of acute flaccid myelitis this year with Enterovirus D68 detected, but no very large spike detected as of yet. Interestingly, the other thing that has happened this summer at our hospital is a reemergence of Enterovirus A71, which is a very uncommon virus in the United States. And the last time we saw it in Colorado was 2003 and 2005. But this spring, before the Enterovirus D68, we had an upswing in Enterovirus-positive neurologic disease, and this was shown to be by typing to be due to Enterovirus A71. Thus far, as of last week, we've had 35 confirmed cases, many with evidence of brainstem encephalitis, a number with acute flaccid myelitis as well. As with your experience, young children, males more than females, febrile illness, almost half with hand-foot-mouth disease, myoclonus and ataxia have been prominent. A significant percentage with autonomic dysfunction, be it tachypnea and tachycardia, variable blood pressure, but fortunately we have not had cases yet of cardiopulmonary collapse, and therefore we've had no mortalities, and in all the 2 cases we've had full recovery. The 2 cases that have not had full recovery have had persistent motor weakness from myelitis. So it's been a very interesting year in Colorado. We've had a double punch from Enterovirus D68 and Enterovirus A71. We hope that they will both go away and not continue to be a problem for us. And I'll stop here. And again, I want to thank you for your invitation and for your attention. Thank you.